Hi, everyone. My name is Karen Zusai. I'm the Senior Media Relations Manager in our Communications Office, and I'm moderating the Q&A today with Roby, who we're super glad to have joining us again. So we're going to go ahead and get started. I'll turn this over to Roby for an intro presentation to cover some of the questions that have been sent in already, and then we'll transition right to the Q&A. And feel free, as the presentation is going on, if you hadn't had a chance to submit your questions using the Google form, to go ahead and use the Zoom Q&A function. We'll be pulling questions from that as well. So Roby, I'll turn it over to you.
All right, thanks so much, Karen, for the introduction. Thanks to everyone who's joined. I am back again, so you'll all be sick of me soon enough. But there's just always more to say, more to learn. And actually, there's been a lot just in the last 36 hours to cover. So I tend to let my intros go on too long. I'll try not to do that, but I will try to cover all the relevant new things from the last time we spoke, which was less than a month ago now. Mostly about case trends, boosters, and kids, and then some of your questions that you pre-submitted, and then we'll go back to sort of a more interactive Q&A. So since the last time we met, about 4 weeks ago, cases have continued to decline in most of the US. Actually, the decline in Massachusetts was slower than some places. We'll talk about why that all might have happened. There's not much to say on variants. Everything is still Delta. There's a lot of updates on the vaccine front. There's, I think, more convincing evidence than even last month when we talked that vaccines wane. Boosters have been recommended as of yesterday for a lot more people than had been recommended before yesterday. And as of today, we got our first glimpse at the FDA filing for kids age 5 to 11 from the Pfizer BNT. And we'll look at a little bit of that, although I must confess that this morning has not allowed me to digest it in full, but we'll talk a little about what to expect and how I'm thinking about my kids, one of whom is in this age range. I'll talk briefly about therapeutics, which I don't think I've talked about to this audience before, and then a little bit about our return to work. A lot of people asked about what's next. I'm going to save that for the Q&A, and I'll preempt that by saying I don't know any better than anyone else. This has been a humbling pandemic to try to predict. All right, so let's dive into case trends. So we went through the late summer, early fall wave of Delta, and much of the country has started to improve from that. I'm showing here in a vertical line on each plot where the when the vaccine was approved, and a horizontal line tells us where we are and how that compares to prior times. And so we're still not even as good as we were in the Alpha wave. And so, this is still a pretty high level of nationwide cases. Similarly true for hospitalizations and deaths. And then in Massachusetts, where we are more vaccinated than the average state, I think we've slipped to number 4 in terms of total percent of the population fully vaxxed. We actually have not declined by quite as much, although I think a lot of that is that we never peaked quite as high. And our case counts are actually a little bit better than they were at the peak of the Alpha shoulder, or whatever you want to call this. So we're doing considerably better than the US as a whole, but we've kind of hit a bit of a plateau over the past few weeks. This was updated, not including yesterday's data. Yesterday was the lowest individual day that I've seen, but it's hard to put in a while, but it's hard to put much on one day's numbers. So really until the 7-day average comes down, I will call this a plateau. But as we talked about last time, we've been somewhat insulated from hospitalizations and particularly deaths with these cases because of our not only high vax rate, but disproportionately high vax rate among those at greatest risk for severe illness. I think we're in the 98% range for people over 65 in the state. And then in West Virginia, the least vaccinated state in the country, cases have started to come down maybe even more from their peak, but again, because their peak was higher, their Delta peak was higher. And this remains a really high level. This is basically the teeth of the Windsor peak, even pre-Alpha, right? They're still at case levels like that. It was the highest count for cases, hospitalizations, and deaths even haven't really started to turn a corner just yet. So a mixed bag geographically. I think that's going to hold true going forward. But it's interesting to think, and we got some questions about why these cases have peaked, especially maybe even more prominently in the less vaccinated states. And I think there's a confluence of things. It's always hard to both explain trends and then to, based on that, project them. But I think it's definitely some portion of this is immunity. That's a dangerous thing to say out loud because it leads to sort of extreme reactions at some times, but I do think that some part of that dip is that Delta has infected a lot of people during this last surge, and more so in places that were less vaccinated. Just there were more vulnerable, non-immune people to get. But I think some of this, if you look at the states that are doing poorly now, is weather and season related, and sort of the effects of that either on the virus or on human behavior and gathering indoors. Right, a lot of the North, Minnesota, North Dakota, Montana are being hit more now, places where people are spending more time indoors. That's important because we're going to start to feel that weather soon as well up in the Northeast. And so it's important to keep an eye on what that brings. Behavior has something to do with it. These oscillations that we've seen throughout the pandemic, some of this is people self-tuning to what to case counts and people they know getting sick. And then I will leave alchemy as like, we can't explain all of these things, but cases have come down. They did this in the UK, they did this in Europe with Delta, they did this in India with Delta. They've done this here, but then the trajectories from there have been quite different in those places. The UK, for instance, hit a pretty high plateau. The rest of the EU has come down much lower. And so where we fall on that spectrum, I think, remains to be determined and will very likely be heterogeneous by place based on a combination of all of these things and probably others that I'm not thinking of. All right, I'm not going to belabor the variants except to say, wow, this was Delta's growth from April to July. This is Delta's persistence from July till now. It's all Delta. There are sub lineages that are emerging, but so far, we're keeping a close eye on them, as are many people around the world. So far, there's nothing that I'm think is worthy of bringing to this group's attention quite yet. There's one in the UK that seems to maybe be outcompeting other sublineages, but Delta, the sort of parent Delta, is still the most common thing there. It's still by far the most common thing here, and there's nothing that's really convincingly displacing it yet. We're keeping an eye out. All right, so then on to vaccines. I mentioned one of the things I wanted to cover is more evidence for waning. I still think the best evidence for waning is the crossover data that I presented. I think it was the last time I spoke, maybe it was 2 times ago, but I think it was last time, where from the original randomized controlled trial, they got essentially a group that had been randomized to get a vaccine 12 months ago versus 6 months ago. And those with 6 months who got it 6 months ago were more protected than those who got it 12 months ago. That's still our best data that it happens. It's important to remember that there were very few severe cases in that crossover, in either of those crossover trials. And in general, it's remaining very effective against hospitalization and especially death. We'll come back to this in response to one of your questions. But one of the studies that I just can't avoid talking about was a remarkable contact tracing study out of the UK, where they traced literally 150,000 cases from 100,000 contacts, not just for a study like this was part of their public health outreach, but they kept track of all of these data, and they were able to learn, because of that, they were able to learn a ton of time resolved data from this, because 100,000 cases, even spread over the 6 months or so that they were doing this, encompasses 2 variants. It encompasses, they can break it down by week. They can break down by week since vaccine. And so this is the summary. It's a really, really rich preprint. If you're interested, I urge you to check it out. There's a lot of nuance I won't be able to cover, but basically what they found was that vaccines are a little bit less effective against Delta than they are against Alpha, that they start out more effective than they get over time. So this upward trajectory here is waning, and that this is seen both on the side of being infected if you are a vaccinated versus unvaccinated contact, and on the transmitting side. So if you're vaccinated and you happen to get infected, how likely are you to spread it? So how likely are you to get infected is on the right. How likely are you to spread it is on the left. And you can see there's better protection. This is farther from the unvaccinated comparator. You're more protected from getting infection than you are from transmitting it if you happen to get infected. But you see a protection on both sides. So you're both less likely to be infected if you're vaccinated, and even if you're infected, less likely to spread it. But both of those things wane. I'm going to ignore the AstraZeneca for now, just because we're in the US, although it's quite concerning, especially on the transmission side, to think about globally the places that's been used. But the Pfizer vaccine, which is probably similar for the Moderna vaccine, so 2 of the major vaccines we use in the US, those start quite good, but wane in terms of protecting contacts from getting infected. And they start less good and also wane in terms of preventing transmission. So I think this is, it's an observational study. So behaviors can't be disentangled. People who get vaccinated are fundamentally different than people who don't in sort of the choices that they've made. And that can't be really untangled. That's why I like the randomized trial best. But this is such a large body of data that I think it really informs the waning question sort of. And the other thing is, it's waned faster than, we know that at 6 months there's problems. This is starting to suggest that even by like 1 to 2 months, we're seeing it's less effective than it was at the first, 2 weeks after the second dose. All right. So most of what I was going to talk about in terms of data today is boosting, because we've had a ton of data come out in the last week and a big decision made yesterday. And so the data that I'm going to share is about mixing and matching, and then soon we'll get an efficacy study too, but this is first just antibody levels. So the antibody levels after the boosters are really impressive. So we know that vaccines wane, but we know that if you give a boost, that antibody levels, which have waned along with efficacy, the antibody levels go way the heck up. They actually are higher than they ever have been after the 2-dose series by about 3 to 10-fold, right? These will be the highest antibody levels that anybody ever gets. And so I'll break down the mix and match data because it's a pretty complicated table. And I'm going to start with Johnson & Johnson because that's the question that we've gotten the most. It's the least effective single vaccine against Delta of the 3 that are approved in the US. And so a lot of people have been asking what they should do in terms of boosting. And before literally yesterday, all I could say was it's just not approved, and we didn't even have much data. But in the last week, we've gotten data, and as of yesterday, we have approval. So what have we learned? Well, so I've covered up everything. So everything that I'm showing now is people who got their initial series or dose of J&J, and then they got boosted with either Moderna on the left, another J&J shot in the middle, or Pfizer on the right. And what you see is all of their antibodies levels gets boosted. So there's how well the antibody binds to the spike protein and how well it neutralizes the actual virus. I'm going to focus on the bottom because it seems to be a bit better of a predictor of activity, of protection. And what you see is the boost. There's a boost from all of them, but it's considerably larger for Moderna and Pfizer. If you get boosted with Moderna and Pfizer than if you get boosted with Johnson & Johnson. Now, this is just antibody levels. To my knowledge, we don't yet have efficacy data, but this has mapped pretty well onto efficacy. And so the FDA's decision was to permit any boost after J&J. And this makes me think, especially if you're a young woman, because there's more risk to J&J in that situation, that you might want to consider getting one of the other vaccines as your booster. Again, it's going to be one shot either way for a boost. And so that would be my instinct from these data. The official recommendations are get whatever you want. But this is a log scale. It's a pretty big difference, in boosted antibody levels. It's more than 10-fold with Moderna or Pfizer compared to the J&J boost on top of J&J. Okay, if you originally got Moderna, basically everything boosts you pretty similarly. And if you originally got Pfizer, same. You get a nice, 10-ish fold boost, whether you get boosted with Moderna, J&J, or Pfizer. That's true for both of the mRNA platforms. And so, how do you make this decision? Well, they all increase your antibody levels above where they are now. And that seems to translate into better protection. We have hard and fast evidence for that in a minute that I'll get to for Pfizer that came out yesterday. The other things to think about are the side effects, I think. So the most dangerous side effect that we've encountered is blood clots after the Johnson & Johnson vaccine. This tends to happen, 5 to 1 or more in women rather than men, and more in younger sort of premenopausal women who tend to be more prone to clots, to clotting issues. It's very rare. It's less, at most 1 in 100,000 and probably less than that. There have been exactly 5 cases of this being fatal in the US out of tens of millions of doses given. There's been 47 cases documented in the US. Myocarditis, as the flip side on the messenger RNA, for both messenger RNA vaccines, it's more common in young men, as is actually spontaneous myocarditis, like non-vaccine associated. That also is more common in young men. It's rare, but not as rare as the blood clots. It's more on the order in men from 12 to 25. It seems to be as much as 1 in 10,000. So still 9,999 times out of 10,000. People don't get this, but about 1 in 10,000 times people get myocarditis. This tends to be much milder than the J&J, which is not to trivialize it. I would rather not get it. I'd rather my son not get it. But we'll come back to sort of thinking about risks in kids, but it's something to know about. It happens more often than with J&J. And so there might be a shading for females to get the mRNA vaccine, for males to get the Johnson & Johnson, but just because the risks are the opposite, but there's other factors at play too. The risks from boosters, as opposed to the primary series, are not yet very well quantified. These were relatively small studies and it's relatively early. We know that there's not been reported cases of myocarditis or clots after these booster studies, but the numbers aren't big enough. So a lot of this that I'm talking about here is extrapolated from the primary series. There's the initial data, and I was planning on just showing this until yesterday when something new came out. So I won't spend too long on this. This is observational data. It's all out of Israel. We talked about this before, that Israel rolled out their vaccines faster than anyone. So they saw waning faster than anyone. They also jumped on that and boosted quickly. And so now they've seen a lot of benefit. And so I drew a red line here. This is separating by age. Again, this is observational. So folks who chose to get vaccinated compared to infection rates in them compared to those who chose not to. And there's a lot of possible confounders. But I drew a line at 10-fold protection compared to other vaccinated, fully vaccinated people from those who got boosters. This is really striking data, right? So basically at every age, there seems to be a more than 10-fold protection for getting a booster compared to being fully vaccinated at baseline. This is obviously all in the Delta era. This is all in the last couple of months. And the other thing that makes this more convincing to me is that there's this about 2-week lag before you start to see that degree of protection. And I can't see why behavior would sort of follow that kind of immunologically plausible timescale, right? So I think this is real. This is another way to plot the data from Israel that's just striking, right? So they had cases rising with Delta as everybody else in the world did. They started rolling out boosters on July 30th. 2 weeks later, but only to those over 60. 2 weeks later, the case rates in the over 60 crowd plummeted. The case rates in the below 60 kept going up. I mean, I guess it's possible that some sort of wild series of coincidences could explain this, but I think this just basically tells you that the boosters are surprisingly effective on a background of people who are already vaccinated. And if there was any doubt, I'm convinced now that an actual randomized controlled trial of a booster, kind of the perfect study that you would want, just was released. It's press release only, but they released some data. And here's how it worked. 10,000 adults, I believe from their primary series, but I'm not sure, based on the dates, but I'm not sure of this, had all gotten 2 doses of the Pfizer vaccine about 11 months ago, and then got randomized, or 11 months prior to randomization. Then they either got randomized to get boosted or to get a placebo instead of that boost. And then they followed them for 2.5 months. This is all during Delta. Like this study must have closed just a couple of weeks ago. And they found that those who got boosted, the half of them that got boosted had 5 infections among the sort of 5,000 folks, compared to 109 in the group that got a placebo instead of a boost. So that's a 95% boost efficacy. That is stunning when you're figuring that you're comparing it to already vaccinated people. It tells you that we had waned a bit, right? But it also tells you that folks with vaccines are still much more protected than folks without. And so the 3rd dose probably gets you to like 98% or better protection compared to an unvaccinated, non-immune person. It's striking. And I think it suggests that this is just a 3-dose vaccine series, fundamentally. So the bottom line is the FDA and CDC approved boosters for a lot of folks yesterday. I think I have a part that talks about who in the next slide, in the next click. But I wanted to just get to how often will we need to do this? The fact that we have to do this is like, it's amazing it works this well, but it's sort of depressing that we're in a place where we can still get 95% better than where we were when we thought we were fully vaccinated. I'd say cautiously optimistic that this does not mean we need every 6 months or even every year boosts going forward. A one-time boost at 6 months or more is actually common for inactivated vaccines. I can't think of a single inactivated vaccine, although I haven't researched this fully, that does not require a delayed boost, right? I think that's just sort of how our immune system works. It needs to be reminded of something to have really durable, strongest possible protection. And so the fact that we seem to be in a place where boosters are really helping now doesn't mean that we're going to get back to this place every 6 months. I'd actually be surprised if that were true, although I don't think we can say for sure without letting time pass. The other thing is this may depend on circulating case levels, right? Like I'm not sure the measles vaccine would hold up if there was this much measles around. I know that anytime I go into a patient room with measles, I am still wearing a mask and I'd get fired if I didn't, right? I'm fully vaccinated. But like, if we were encountering it multiple times a week, we might need a boost for that too, right? So I think if we get cases down, that also I think will affect the boosting interval. Okay, so boosters. Boosters were approved yesterday. Everyone who's gotten J&J, and it's been more than 2 months since you got your dose, you're eligible for a boost. And personally, I think it's a good idea to get one based on the fact that you can get a 95% better protection than even the messenger RNAs gave you. You're probably starting from a lower baseline than folks with a messenger RNA. So, go get them if you had a J&J, and you can pick your choice, honestly. Again, remembering that the messenger RNA vaccines boosts give you higher antibody levels, but maybe have greater risk of myocarditis. We don't really know the risk in the context of post J&J. Some Pfizer and Moderna recipients who have been more than 6 months since the 2nd dose, and the way that this is currently approved is for everybody who's over the age of 65 or folks who are living in a skilled nursing facility, because that implies both congregate living, meaning high exposure, and probably some comorbidities that make you at higher risk for severe disease. And then also extended to high-risk adults. And that means either you're at high risk of, if you get it, you have severe disease, or you're at high risk of exposure. And that's basically meant because of your job or your living situation. You live in a group home, or you're a healthcare worker. I got boosted a couple of weeks ago now, based on the sort of healthcare worker provision. And then again, mix and match. I think we've talked about all of this already. So I will move forward in hopes of getting to questions. But again, I can't leave boosters without saying boosters are great. They clearly are going to, I think they're going to make a difference in disease rates in the US. They are much less important than first doses. That's true within the US, that's true across the world. And that's because of the effect of first doses on severity, of the initial immunity event on severity. Like everybody in Africa who's not been infected is at great risk, or 95% that are still unvaccinated are at greater risk than ever of severe outcomes if and when they get infected. And as I said last time, third doses to the US, like it's not a personal decision. You're not choosing whether you get a vaccine or someone in Africa does. I would not have gotten boosted if that were the choice. Those doses have been allocated to us. Our use of them does not drive demand. In some ways, it prevents them from spoiling. And so I try to separate the science of, do boosters help? And are they helping my family, the patients that I'm seeing, me, versus what is the equitable policy position to take? Personally, I ended up making the choice to donate to vaccine causes for the boost, right? Just to sort of offset the boost that I got. All right, kids. And I think this is one of the last topics before we get to your questions, although this is already, many of the questions were about this. Kids as young as 12 are eligible now. Only Pfizer went below 18, but Pfizer goes all the way down to 12. And Pfizer applied for authorization a couple weeks ago for 5 to 11. This is using 1/3 of the adult dose. 12 and up all got the full adult dose. For this age window, the dose is 1/3 of the adults, and the data were released today, not reportedly anymore, they were. Then the FDA will be considering them next Tuesday. So based on the press release that they put out a couple of weeks ago, the antibody levels were excellent. And that's basically on the basis of which they applied for approval, right? Antibody levels are the same in this group as they were for the 18 to 25 who had more rigorous efficacy data. That's usually enough to approve pediatric vaccines. They also mentioned there was no myocarditis, and that's been now confirmed in the release from the FDA today. Only about 2,500 kids got vaccines, so that's not perfect, but it's probably not like much higher in this age range, at least you can say that. And the side effects, they say, were similar to older kids. Here's the efficacy data. So this was not sort of meant to show efficacy. They meant to approve it just based on antibody levels. But once again, these vaccines are proving very efficacious. So all Delta, 2 doses, 90% effective. This is just hot off the presses this morning. 16 cases in a placebo arm, only 3 with vaccine. And this was a 2-to-1 randomization. So twice as many kids got vaccine as placebo, and still 1/5 the number of cases. So greater than 90% efficacy, which is wonderful. And just to say it, there's a lot of nuance around the discussion of kids. We may come back to this as a group later after they get approved. We'll see. But I'll just say that I plan to vaccinate my 6-year-old as soon as possible, my 3-year-old as soon as it's possible for him. They're going to be in different groups. I will look at the data. I will have, reserve the right to change my mind if things don't look well. But my thought on this, so there's a lot of news out there. COVID is clearly less severe in kids than in adults, but I think that's just not the right comparison, right? Every life is less likely to kill kids than adults. The age dependence of death from COVID is not different than the age dependence of all-cause mortality. So I think the right comparison for kids is to other things that affect kids. It's actually not better for kids that adults do badly. It's worse for kids that their parents and grandparents are at risk of dying of this disease that they might contract, right? So you think of kids on their own. But I think the other part of that is you don't want to get scared off by mortality in 65-year-olds and make your decision for kids. But it's not that reassuring, right? You consider kids on their own. Other things are worse for kids. Car accidents are more likely to kill kids than COVID. Well, sure, but if there was a vaccine for that, I'd give it in a heartbeat too, right? So again, not the right comparison in my mind. It's just, in my mind, your kid, everyone is going to see COVID. And is it better to see COVID naive, or is it better to see COVID after you've been vaccinated, but taking the risk of the vaccine? And in my mind, this is an easy comparison, that COVID is terrible. COVID is much worse than I think any vaccine that's ever been approved. So unless there are real alarm bells in these data, I will be first in line with my kids. COVID's killed about 600 kids under the age of 18 in the US. This is from CDC data. Some other estimates are even higher. It's a leading cause of death in all ages. This was even true before the Alpha and Delta surges of last winter and this fall. It was already, just from 2020, up through October, it was one of the top 5 causes of death at every age, including kids. So yeah, I think COVID is just pretty objectively clearly worse than the vaccine in my mind. And so anyway, my decision for my kids will be to vaccinate them as soon as I can, again, barring anything unusual in the data that get released between now and then. People asked about when to expect 2 to 4-year-olds to like the younger ages below 5 to get approved. I would expect, Pfizer is saying they're going to submit in a couple of weeks. We're already a couple of weeks out from when they submitted for 5 to 11. So that puts it at least a month behind. And I think it's, is this going to happen? Is this really going to happen? So I think 5 to 11, FDA hearing on Tuesday, CDC meeting, I think the following week. And so first week in November, we might be giving doses. I would say it's at least a month behind that, and maybe more like 2, as just a hunch. And I have no inside information on that other than what like Pfizer is telling the press. And then 6 months to 2 years after that. And basically they step down in ages to get make sure that a dose is tolerated by the older group, and then they introduce it to the younger group, and they do that stepwise. And that's why there are these lags built in. Okay, a little bit on long COVID. We finally have a little bit of data. Not all of the data that I think many folks are hoping for. It has gotten the name PASC, post-acute sequelae of COVID-19. And the data that I wanted to share is just that vaccination in people who already have long COVID, who have PASC, seems to help. It's not a magic bullet, but it seems to decrease, it seems to increase the rate of complete remission of symptoms by about 2-fold, and to improve the symptoms overall. Like there's a small subset that get worse and a larger subset that get better, and then some chunk in the middle that report no change. This was a controlled, I don't believe it was I actually can't recall if this was a randomized. Yeah, not here. I said it here. Not a randomized controlled study, but they matched by sort of comorbidities and symptom complaints before the dose, and they sort of matched people who either chose to get the vaccine or chose not to. And those who chose to get the vaccine were more likely to report complete remission. There's still no great data on incidence in the Delta era. Or for incidence in post-vaccine infections. I'm still keeping my eye out for that. I haven't seen good studies of that. I know they're underway. Wanted to talk briefly about therapeutics, mostly just to say that we're getting better at treating this. I don't think that's a point I've made to this audience before, but there's 3 major classes of antivirals now, I guess 2. Monoclonals, so those that sort of act like vaccines in that but except that they're artificial, they're external antibodies that we give to people. These really work well to reduce hospital admission in folks already infected. And they've even, so 80% reduction in hospital admission. They've even shown good data for post-exposure prophylaxis. So if you know you've been exposed to a case and you're high risk, there have been studies of giving you monoclonal versus placebo, and monoclonal really helps you from getting infected, and if you get it, from getting severe disease. There are even longer acting versions that are being studied as pre-exposure prophylaxis. This is exciting for folks with compromised immune systems. You could imagine getting periodic infusions while case counts are this high that will protect you for months on end. We don't know this to be true yet, but I think it's plausible and it's being studied. Then there's polymerase inhibitors. There's an IV form and an oral form. The IV form was used a lot in the hospital and was mixed results at best, but I think a lot of that is because by the time you get to the hospital, you're pretty late in illness. When it's given early, when anti-infectives have their best effect in kind of all infectious diseases, it's worked really well too. It actually looks, the top line number from a press release is again, 80% reduction in hospital admissions. But this requires IV doses in the outpatient setting. There's an oral anti-polymerase drug that's just again in press release and sort of meeting abstract form that is not quite as potent. It reduced admissions, or not quite as efficacious, reduced admissions by 50% instead of 80%, but that's pretty amazing. On the other hand, that kind of just takes you back from Delta to pre-Delta, right? Because Delta is maybe 2 times as likely to land you in the hospital, but still helpful. And then we're sort of fine-tuning the immunomodulators in the hospital as well. I think I won't go deep into that. And then there's one drug of completely unclear mechanism that's been really promising in trials, fluvoxamine. It's an antidepressant, and it maybe has some off-target effect on platelets that prevents blood clotting. And if you have questions, I've thought about it, but I don't think that I have a good mechanistic model for this, but it really, in several different randomized controlled trials now, seems to work well in the outpatient setting. All right, we're coming back to work. We're masking in public spaces. We have hybrid meetings as needed. Eating and drinking is a challenge. And there are we've done about 3,000 tests for the week of October 12th. So the week that we were sort of targeting for, it's all gradual, but there are sort of, if there was a full return week, that was it. There were 3,000 tests done that week and 3 of them were positive. So remaining at a low level, I just learned a dashboard. You can screen grab this if you want and follow it on the intranet that lets you follow along for all of the testing results. Obviously, they're all aggregated and not obviously personalized, but that is a neat resource that's being provided. So I just thought I would leave this. You've seen this from me before, but as we think about coming back to work, the things that keep us safe with cases as high as they are still, even in Massachusetts. So especially if you're someone who is immunocompromised in some way or living with unvaccinated folks, these are the things that I keep in mind. So to keep myself as safe as possible for my unvaccinated kids, that vaccinated is safer than unvaccinated. Now boosted is safer than unboosted if you're eligible. Your state of health is also really important. I'm making red things that you can't really control, but you can know and act upon. Being outdoors is always safer than indoors. Testing is rapid or PCR. If you've recently tested negative or those around you are, that's safer than if you haven't. Lower case counts, more ventilation, out of your control, but important to know about. And then masking, keeping your exposure time short and distance. This is the Swiss cheese model. You've seen this before, so I'll move through it. So a couple of your questions that I thought I'd lead the Q&A with before letting Karen ask them. Someone asked what percentage of hospitalizations and deaths are in the unvaccinated. And this is a complicated, sort of surprisingly complicated question as you dive into it, because the more that we vaccinate, obviously, if 100% of people are vaccinated, 100% of hospitalizations will be among vaccinated people. So the more you vaccinate, it's called a base rate fallacy, the less impressive this looks. That's especially true because we're trying to vaccinate the people at highest risk first, and we're succeeding for the most part. Those are the most vaccinated people. And yet, those who are unvaccinated, despite being at lower risk to begin with, are 10 times, 11 times as likely to die as those who are vaccinated. For hospitalizations, I've seen, and that, again, that really understates the advantage of being vaccinated because it ignores the fact that we're vaccinating high-risk people, and those who are left unvaccinated are on average at lower risk, and still this is true. When you start to adjust for age, it's even more impressive. There's like a 50 to 70-fold reduction in hospitalizations if you're vaccinated in green than if you're not in blue after adjusting for age. And again, I guess my favorite couple of stats on this. So the Connecticut DPH tried to do an age matching for death, and they came up with about 75-fold lower risk of death if you're vaccinated. And then the UK report, this is just staggering, 37% of all deaths in the year 2021 in the UK among unvaccinated people of any age, more than a third of deaths. If you were unvaccinated and you died, there's a more than 1 in 3 chance that it was because of COVID. If you were vaccinated, that chance was only 0.8%. So this actually encompasses a lot of those controls that you want. And it's 50 times different. It's crazy. This virus didn't exist 2 years ago, and it's causing a third of the deaths among unvaccinated people in the UK. Bananas. Okay, and then the last question before I turn it over to Karen was people asked about correlates of protection. And I would say it's very clear that antibody levels are correlated in some way with protection. No threshold has been set. This is just a cool paper, if you want to pull it from Nature Medicine, that shows the average neutralization titer elicited by a bunch of different vaccines and the way in which, and their efficacy. And it's not a linear relationship. And this leads to some sort of like nuanced behaviors and maybe non-intuitive behaviors. It's a nonlinear decay of efficacy, but there's very clearly a relationship between. That doesn't mean it's causal. It's not antibodies aren't the only thing. But there's a clear correlation, but nobody has yet set a threshold. So you can't like go get a blood test and say, I'm good. But clearly there's a relationship there. So I'm going to stop there. I talked way too long again. I hope that was interesting. And I will turn it over to Karen for some of your questions.
Great, thank you, Roby. So we've got 11 minutes and we'll try to get through as many as we can. So there's a bunch of questions about the future, both immediate future in terms of the holiday season coming up and long-term future in terms of, have we seen the way we interact in public spaces change permanently? And, what are your thoughts on that?
Yeah, so they're both great questions to which I don't have clean answers, but I think that going into the fall and winter with this many cases, I would expect them to go up from here because people will start spending more time indoors. There will be forces pushing them up, right? So people will be spending more time indoors. It's harder to eat outside. It's harder to gather outside in December in Boston than it was in June and July, right? In addition, there seems to be some seasonality for coronaviruses. We don't know this for sure with this one because we haven't been through enough seasons that there's so many variables changing at once until you see many years of patterns. But other coronaviruses, November through February is high season, and we might be running into that again next month. The forces acting against that is a lot of people have immunity by this point. 69%, I think, of adults in Massachusetts have been vaccinated, fully vaccinated. Kids are coming online soon, and a decent chunk of the rest, if it's maybe half of the rest that have been infected by now, and that's a little bit pulled out of my hat. We're up to 80% in pushing with kids. So I think that cases will probably bump from here, but I'm not sure of it. I think hospitalizations probably won't, because again, we're at like 99% of the most high-risk people have been vaccinated. So it's not to say they won't at all, but I think like with the initial Delta surge, we will be shielded from that. I think places where those things are not true, where the high-risk people are not well vaccinated, I think they are at risk for more cases, more hospitalizations. And then I really think it's an interesting question about the long-term effects of this pandemic. And I thought for more than a year now that this was going to be a before and after moment for us as humans having lived through it. There's some interesting data out of polio, the polio era, that like literally baby boomers were held less by their parents, perhaps because than like prior generations, perhaps because parents were fearful of sort of fomite spread, fecal oral spread of polio, and kids were dying of polio. And it led to a whole generation parenting differently than they used to. So like, I don't know, I can't predict this. And I don't think we're going to be wearing masks for like in 10 years. I could well be wrong, but I think if we do, it'll be because of another pandemic, not this one anymore. But I don't know how this intermediate period goes. I think there's going to be a little bit of time before this gets down to sort of a baseline level. And then we'll have to decide what we accept. And some of that will be conscious and some of that won't be. So I'll be really interested to watch, but I don't have a clear prediction.
We're seeing a lot of questions come in about the hybrid immunity, either people who were infected and then got vaccinated, or who were vaccinated and then got infected. What do we know about that? How strong that type of immunity is, how long it might last in either scenario, and should those people get boosters if they're eligible?
Great questions all around. I don't think, to cut to the chase, I don't think there's good data on that last part of the question of whether boosters will be helpful. It has been clear for some time that antibody levels, at least, are highest in folks with previous infection who are subsequently vaccinated. That's higher than any of these vaccines. I think the boosters maybe get people closer to that, but I still think like the best immunity there is, I wouldn't recommend it as a strategy. The best immunity there is that we know of is folks who had a prior infection, survived it, and then got vaccinated subsequently. So I don't think we know really whether those folks need to get boosters. The reverse, vaccinated first, subsequently infected, I have not seen as good data on that. Those were relatively rare until the Delta era. And so I just haven't seen as much data on sort of protection from subsequent infection or even antibody titers. It's just not as not as much in the literature that I've seen. But it's a good question. The recommendations out of the leadership groups have been to just get vaccinated and not pay attention to that fact. Whether that's your decision or not, I think I've spent less time trying to convince previously infected people to, my primary, where these do the most good is the less immunity you have, the more good another vaccine does you. I would say in the Delta era, I would definitely get the vaccine series, even if you had a prior infection. Would I get boosted? I mean, honestly, personally, I probably would, but I think that enters more in the realm of personal risk benefit with imperfect information.
All right, going back to the topic of kids, for parents with young kids who are too young to be vaccinated, if the parents are vaccinated, if the kids are interacting with vaccinated individuals who are out and about, either everything from healthcare workers to just people who are out eating with others, what's the risk that we know of now that these people could transmit to young unvaccinated children?
Yeah, it's a good question. So some of the UK contact tracing study gets at this as well as anything that I've seen, right? We know that vaccinated people can transmit. They are less likely to become infected. They are less likely, if infected, to transmit, but both are clearly possible. There's just a preprint out of, so maybe a dozen or so Broadies were on out of the Provincetown outbreak that very clearly genomic epidemiology proved even to vaccinated people spread. So this clearly can happen. And so it's less likely, but not that unlikely given where case counts are. So how do you deal with this? I mean, I don't have a clean answer, but I can tell you what I do in my household, if that's helpful, which is that when we are still selective about who we hang out with indoors. We hang out outdoors. We do outdoor play dates. I feel pretty good about that setting, but we don't have indoor play dates the way that we did 2 years ago. And even when my parents come to visit, or my wife's parents come to visit, we will ask them to be careful beforehand, and we will test them when they arrive. Is that over the top? I mean, someone else asked, am I being, I forget exactly what the phrasing was, but one of the questions was like, am I being rational? Am I being ridiculous? Is it both? And I sort of think maybe it's both, but that's how we're acting right now.
Cool. In terms of side effects, getting a couple questions on side effects of boosters or vaccines for people who are pregnant and also for transgender individuals who may be on hormone replacement therapy. And what do we know about the side effects for those populations?
great questions. So for pregnancy, I don't know of booster specific data in pregnancy, but it's getting more and more clear that pregnancy is a striking risk factor for severe disease. And that the recommendations are more and more clear that we want to vaccinate pregnant women, that it's pregnant people, that it's safe, and that it's effective, and that it prevents severe disease. How that extends to boosters, I just don't think there's data to guide. Personally, I don't think there's reason to think that the booster would be worse in pregnancy. Antibody titers antibodies cross the placenta. This is like how humans evolved, and so it will give some protection to the newborn more if those antibody levels are higher. Breastfeeding similarly. So, this is decisions made again on incomplete data. My instinct is to say I would lean towards getting as much protection from COVID as one can, because COVID is bad in pregnancy. Transgender individuals, other folks on hormone replacement therapy, I don't know, again, of actual data on risks. I would say, based on what I know of the physiology of Johnson & Johnson, I might be a little bit leery of Johnson & Johnson if on estrogen replacement therapy, because estrogen is coagulopathic, but this is definitely me talking out of my head. I don't know studies to support this at all, but I might lean towards a messenger RNA vaccine in that case, for either a primary series or a boost. I think in the Delta era, I would lean towards a messenger RNA vaccine as a primary series anyway, but for a boost, I think I would lean that way, just because the risk of clot might be higher if you're on estrogen.
One of the questions that came in from the Google form earlier was about surfaces. And we, early in the pandemic, we heard a lot about surface transmission. Haven't heard a lot lately, or even in, over the last year. Is this still something we should be concerned about? I
think this is mostly about shared air. I think this is an interesting case for like the science of respiratory virus transmission, that I think more things are shared air than we expected. And I think fomites, it's not to say don't wash your hands, especially if you're immunocompromised. There's a lot of good reasons for that. I would say that COVID is relatively low on that list. It's really about minimizing shared air. So protecting your airway masks and protecting your immunity with vaccines, I think are major ways. We're not washing, we've been washing our groceries for a long time now in our household.
All right, and with our last couple minutes here, there's a couple questions again about the immediate term, like Thanksgiving is coming up. People want to know, is it safe to host unvaccinated people? What should we be concerned about if we're, thinking about family gatherings? Should people get tested ahead of time? What do you recommend if,
Yeah, so I would say this is all individual risk, and but the way I think about it is sort of what could happen, right? So how likely is it that someone comes to my house infected? That's about 10 times more likely if they're unvaccinated than vaccinated. It depends on where they're coming from, how likely it is, right? From Massachusetts, less likely than from a less vaccinated state, or a place like Minnesota, which may be vaccinated but has a lot of cases, right? Then who's at risk, and how much at risk are they if they get vaccinated, and how willing am I to accept that risk? So if I'm living with my father who has multiple myeloma and is on a couple of immunosuppressive therapies, that's not my father, but like a hypothetical father, right? If I'm living with someone who is at great risk of severe disease if they get infected, I'm going to be much more careful. If I have unvaccinated kids, this becomes a personal risk question. I feel like we are so close to my 6-year-old daughter getting a vaccine that I'm not going to bring unvaccinated people into my house for a month at least until she is. And then what am I going to do with my other kid who's going to be a little bit while longer? Well, my parents are coming, they're vaccinated, they're actually now boosted, and they're going to test before they get here, because it's $10-12 and we're fortunate enough that we can afford that, and so we do that. That's how I'm doing it. It becomes personal risk. I think the big thing is to think about, if someone got COVID, how protected are they? If they're vaccinated and they have a normal immune system, they're not likely to get severe disease. If they're very young, they're not likely to get severe disease, but you might want to, we're close to that vaccine threshold. If you can stop them from getting an infection over the next month, they will never get an infection before they're vaccinated, right? And that's a pretty big change. It's not like it's just punting it down the road forever. It's punting down the road to an endpoint. But yeah, and then the real thing is immunosuppressed people or the elderly. If I'm seeing them, that to me, that raises the stakes a lot.
All right, and that brings us to noon, which is the end of our time. I know there were a lot of questions. There were 40 that came in over Zoom. There were a lot that had come in ahead of time, and we didn't get to all of them. But thank you so much, Roby, for this wonderful information wealth and sharing your knowledge and giving us some things to think about.
Thanks for the interest. I will do my best to look over lists of questions that are sent to me and see if we can post them somewhere. But thanks everyone for continuing to come. It's remarkable how many folks come to these.